Welcome to the deep dive. We take complex info and give you the essential insights you need. Today we're focusing on, well, the longest phase of our lives, really,
Yeah.
adult nutrition, specifically ages 20 through 64.
Yeah, this is definitely the deep dive into the long game. If everything before 20 was about building the foundation, these next 4 decades or so are really focused on preservation. The central mission here, based on the sources, is maintaining health, keeping a stable weight, and actively, preventing chronic diseases from setting in.
Okay, let's unpack that timeline a bit. Because adulthood isn't just one big block, right? It kicks off with early adulthood, your 20s and 30s. This is when independence really hits. People are building careers.
And maybe learning basic life skills like actual meal planning or cooking for the very first time. Then later, sometimes nutrition comes back into focus, maybe, as the source puts it, for the kids' sake.
Right. Then you hit midlife, the 40s and 50s, often peak responsibility time, especially for what the sources call the sandwich generation.
Mm-hmm. That's people, often women, juggling families, careers, and caring for aging parents. It's a lot. And crucially, this is when health concerns really start to pop up more frequently, especially in the 50s.
And finally, there's later adulthood, the early 60s, often a transition towards retirement. Maybe more focus on lifestyle factors then, partly because managing a chronic condition might already be a reality for many. So what's the big picture urgency here?
Well, the urgency is frankly staggering. We know about half of American adults are dealing with one or more preventable chronic diseases, and over two-thirds are overweight or obese. Poor diet patterns link directly to three major risk categories:
HR?
the carcinogenic diet boosting cancer risk, the atherogenic diet that's accelerating plaque buildup, cardiovascular risk, and the obesogenic diet, which is basically just chronic excessive energy intake. Too many calories consistently.
It's fascinating, though, how complex the why is. Nutritional status isn't just about your individual choices day in and day out. The sources really emphasize these powerful external factors, what they call the social determinants of health.
Exactly. We're talking about big structural things: economic stability, the kind of neighborhood you live in, access to fresh food, the education levels, healthcare access. These things largely determine who gets the resources for good health, and that creates major health disparities.
And you see that clearly in the data. Like obesity, it varies a lot by race, ethnicity, income. And here's an interesting point from the source. Among white women, there's an inverse association. Lower income correlates with higher obesity rates.
Yeah, and then you have genetic predispositions layered on top, like higher diabetes rates in Native Americans, or how African Americans often show greater sensitivity to salt.
So it's a really holistic picture.
It has to be. And the government recognizes this. That's why a big goal of Healthy People 2030 is eliminating these inequities. They want to create environments that promote health for everyone. There's specific nutrition targets. Pretty concrete.
Like what?
Dropping adult obesity from almost 39% down to 36%. And beyond weight, improving intake of whole foods, fruits, veggies, whole grains, while really dialing back added sugars, saturated fats, and sodium.
Okay, let's shift from those external factors to what's happening inside the body. Physiologically, what are the milestones during this huge chunk of life? We know we hit peak bone mass, peak muscle strength around age 30.
Around 30, yeah. And then the sources talk about these climacteric changes.
Which means?
It refers to the gradual winding down of reproductive capacity. For women, that means perimenopause and menopause, usually hitting in the early 50s. And the research is really clear. Menopause links to a significant increase in abdominal fat and faster bone loss.
And for men?
Men see a slower, more gradual decline in testosterone and lean muscle mass, also starting after about age 30.
Now, there were two really modern insights in the research about what drives age-related decline that jumped out at me. First, immunosenescence.
Right, fancy word for the immune system gradually declining. It often shows up as low-grade chronic inflammation. We used to think it was just aging, but the sources link it heavily to lifestyle, environmental exposures, stress.
And the mechanism behind that inflammation is interesting too, involving fat tissue itself.
Exactly. Adipose tissue, or fat tissue, isn't just storage, it's metabolically active. It's an endocrine organ. In individuals with obesity, the specific immune cells within that fat tissue, called adipose tissue macrophages, or ATMs, actually produce more pro-inflammatory compounds.
Wow. So the fat itself is actively fueling the inflammation that damages the immune system over time.
Precisely. It contributes to that smoldering low-grade inflammation linked to so many chronic diseases. The second big insight is the gut microbiome. Your gut bacteria fingerprint changes with age and diet, and an imbalance called gut dysbiosis creates this profound inflammatory state.
which we now know is linked to.
Not just digestive issues anymore. We're talking cardiometabolic diseases, neurodegeneration, even depression. That gut-brain axis is critical.
That really underscores the need for early action,
They
doesn't it?
do.
To help visualize this, the sources use a framework called the continuum of nutritional health. It lays out 6 stages of nutritional injury.
Yeah, and the core idea here is that the damage starts way before you ever feel sick or get a diagnosis. Stages 1 and 2 are where prevention really matters. Stage 1 is resilient and healthy. You're in homeostasis. Stage 2 is altered substrate availability. Subclinical changes are happening. Maybe nutrient reserves are low, but no outward signs yet.
Okay, and then?
Stage 3 is where you start seeing nonspecific signs and symptoms. Think elevated blood pressure, maybe creeping insulin resistance. Stage 4 is the clinical condition. That's the formal diagnosis, type 2 diabetes, atherosclerosis, etc.
And it continues to stage. Stage 5, chronic condition, and 6, terminal illness. The big takeaway seems to be how insidious these changes are, often unnoticed until stage 3 or 4 when damage is already underway.
Exactly. Prevention in those early stages is everything.
Okay, so if these internal processes are happening, how do we fuel ourselves correctly as our bodies become, well, a bit less efficient? Let's talk energy needs. Unfortunately, we're kind of fighting physics here. Energy expenditure declines roughly 2–3% per decade.
Yeah, and it's highly correlated with drops in physical activity and that loss of lean muscle mass we mentioned. Your total energy needs break down into 3 main parts. The biggest chunk, 60–75%, is your basal metabolic rate, or BMR. Just keeping the lights on, heart pumping, lungs breathing.
Then about 10% is the thermic effect of food, or TAF. That's the energy cost of actually digesting and processing your food.
Right. And the last part, the most variable one, is activity thermogenesis. That covers everything from a planned workout to just fidgeting. It accounts for 20–40% of your daily energy burn.
So how do we estimate those needs accurately?
Well, there are 3 main methods discussed. The research gold standard is estimated energy requirements, or EERs. They use super precise methods like doubly labeled water, factoring in age, sex, height, weight, and activity level. Very accurate, but not practical for everyday use.
Okay, so what's more practical?
The Mifflin-St. Jeor formula. This is probably the most common one used in clinical settings. It balances accuracy and practicality pretty well. It calculates your resting energy expenditure similar to BMR using your weight in kilos, height in centimeters, and age. Then you multiply that by an activity factor.
Like 1.2 if you're mostly sedentary.
Exactly. Or 1.55 for moderately active, 1.725 if you're very active. It gives a pretty good estimate.
And the third method?
Is the really simple ballpark estimate. For many healthy adults, just maintaining weight takes roughly 15 calories per pound of body weight per day. It's rough, but a decent starting point for some.
Okay, let's get practical. Weight management. The sources confirm the old rule of thumb. 1 pound of body weight equals about 3,500 calories. So to lose 1 pound a week, you need a consistent 500-calorie deficit each day.
That's right. And you could achieve that deficit in different ways. Maybe cut 300 calories from your diet, burn an extra 200 through activity, or some other combination.
That margin, 500 calories, sounds big, but broken down daily.
It's surprisingly small. It really highlights how easy it is to accidentally create a surplus. Just 100 extra calories a day, maybe an extra handful of nuts, or a slightly larger portion adds up to 10 pounds in a year if you're not careful.
Wow. Okay, shifting to macronutrients. The good news here seems to be flexibility. The acceptable macronutrient distribution ranges, AMDRs, are pretty wide. 20–35% calories from fat, 45–65% from carbohydrate, and 10–35% from protein. Suggests multiple eating patterns can work.
Absolutely. But where diets often fall short is with specific risk nutrients. We really need to focus there. Let's hit 3 key areas. First, fiber. Most adults just don't get enough, and we need both types. Viscous fiber, like in oats, helps lower cholesterol.
And fermentable fiber.
That's crucial for feeding your healthy gut microbes. Think fruit skins, beans, onions, really important for that gut health we talked about earlier.
Okay, second key area.
Sodium and potassium. They have opposite effects on blood pressure. High sodium constricts blood vessels, raises pressure. Potassium helps relax them, promoting vasodilation. That's a big reason why diets rich in fruits and veggies, which are high in potassium, are so beneficial. It's the core principle behind the DHH diet for hypertension.
Makes sense. And the third risk nutrient area.
Magnesium. It's a cofactor in hundreds of bodily processes, absolutely essential. But inadequacy is common and often goes undetected. Subclinical magnesium deficiency contributes to chronic inflammation, cardiovascular issues, core bone health, it's a big one.
And we should probably briefly mention others too, right? Like calcium, vitamin D.
Definitely. Calcium and vitamin D for bones, vitamins A and E as key antioxidants, choline for neurotransmitter function, and iron, especially for premenopausal women due to menstrual losses, preventing anemia. All still crucial.
So how does all this science translate to what you actually put on your plate? Let's talk dietary guidance, the total diet approach. The guidance allows flexibility, healthy U.S.-style, Mediterranean vegetarian patterns are all recognized. But there are two big cautions.
Yes, two really critical points. First, choose nutrient-dense foods. That means the whole, minimally processed version. Think grilled chicken breast, not the breaded fried patty. Baked potato, not fries. The form matters immensely.
And the second caution.
Portion control. It's huge. The portion sizes shown on things like MyPlate are almost always smaller than what people typically serve themselves at home, and definitely smaller than restaurant portions.
We also need to touch on hydration. The recommendation is about 3.7 liters total water for men, 2.7 for women, daily.
Right, and that includes water from food. But
No.
the key takeaway is that most of that fluid intake should be actual fluids, and plain water should be your go-to. Why? Because sugary beverages are currently the #1 source of added sugar in the American diet. Switching to water makes a massive difference.
Now, to counter some of the potential rigidity of focusing purely on nutrients, the sources mention the eating competence model. What's that about?
It's a really refreshing approach, actually. It shifts focus from risk reduction and percentages towards building a positive, comfortable, flexible relationship with food. It has 4 components: positive eating attitudes, broad food acceptance, less restriction, better regulation of food intake, learning to trust your hunger and fullness cues again, and paying attention to the eating context, like planning meals and eating in a pleasant environment.
So less obsession, more intuition and structure.
Basically, yes, it gives you permission to be more relaxed and confident around food, which can be more sustainable long term.
Great. Let's move to our final section. Physical activity, absolutely key. What are the official guidelines?
The physical activity guidelines for Americans recommend a baseline of 150 minutes per week. That's 2.5 hours of moderate intensity aerobic activity. Or you could do 75 minutes of vigorous intensity activity, plus muscle strengthening activities at least 2 days a week.
And how do you know the intensity? There's the talk test, right?
Exactly. Simple but effective. Moderate intensity means you can talk, but you couldn't sing. Vigorous means you can only manage a few words before needing to pause for breath.
And the push for activity is moving beyond just individual gym memberships now, isn't it? The active living movement.
Yes, that focuses on policy and environmental changes. Things like building sidewalks, bike lanes, zoning for mixed-use neighborhoods, making activity the easier choice in daily life. And what's really compelling is that aerobic activity, even without cutting calories right away, leads to decreases in total fat, and especially that harmful abdominal fat. It directly improves metabolic function.
Important point. Now, what about supplements or ergogenic aids?
For elite athletes, maybe there's a specific conversation to be had. But for the vast majority of healthy adults eating a reasonably balanced diet, the strong advice is food first. You can easily meet your nutrient needs through whole foods. Supplements usually aren't necessary unless there's a diagnosed deficiency or specific medical need.
Okay, so bringing it all together to really make a difference population-wide, interventions need multiple prongs.
Absolutely. You need individual approaches like counseling or telehealth. You need environmental changes like that point of purchase signage in grocery stores, highlighting healthier options. And you need system-level policy changes, things like food fortification mandates or maybe taxes on sugar-sweetened beverages.
Community programs seem vital too.
Totally. Culturally relevant programs that build social support, like the Sisters Together, Move More, Eat Better initiative mentioned in the text, show how powerful community action can be. And we can't forget public programs like SNAP, the largest food assistance program. It directly tackles food insecurity, the struggle to consistently get enough food, which affects a significant portion of households.
Okay, let's wrap up this deep dive on adult nutrition. The big message for these crucial decades.
It really boils down to supporting those interdependent nutrient functions and managing energy balance through 3 key principles: variety, moderation, and balance. And the focus really needs to shift from fixing problems later to active prevention, starting right from early adulthood when the body is still resilient.
That's right. And just think back to that simple ballpark number for weight maintenance.
Mhm.
Roughly 15 calories per pound of body weight. The key lesson, I think, is just how easily that scale can tip. Remember, just 100 extra calories a day consistently leads to a 10-pound gain in a year. It's those small, often unnoticed excesses. So the challenge for you listening is, how much closer can you get to true nutrient density in your daily choices to avoid those silent, creeping calorie surpluses? Thank you for diving deep with us today.